please welcome to the stage Ellen Donahue-Dalton, Chris Spears, Dr. Joni Collins, and Dr. Lucienne Ide.
Hello, everybody. Thank you for having us here. We are so excited to be here with you today and to start this panel on the Partnership Prescription, Innovating Personalized Medicine. We have an amazing panel. We've already had several great conversations about some of the questions that you might have and some of the perspectives that are already out there in the industry. So I am going to start by asking each of our panelists, as way of introduction, to answer 3 questions. I am, we focus on, and I want today's audience to take away these 3 things about personalized medicine. So I'm going to start right here to my right.
Good morning. I am Dr. Lucienne Ide. I'm a physician, scientist, and founder and CEO of Rimidi, a digital health company. We focus on enabling proactive models of care for chronic disease management. So we work with provider organizations to support their work. And the 3 takeaways I have about precision medicine, I'm proud of myself, I'm remembering your questions, is that number 1, I think it's what we all expect in care, is patience. We think this is what we're getting. Number 2, is a provider, it's what we all want to provide to our patients. And I think number 3 is until we align payment incentives around it, we won't see those 2 things to be true.
That was a great answer.
Yeah.
Get to follow that. Good morning, you all. My name is Dr. Joni Collins. I'm a doctor of medical science, a physician assistant, and a certified aesthetic consultant, and the founder of 1228, which started in a mobile Airstream before it was cool in 2017, and I practice regenerative and aesthetic medicine. So basically, that is precision or personalized medicine because we take your cells and we use them for regeneration, whether it's aesthetically or your full body. And to me, third question, right, is what is precision or personalized medicine? And to me, it's threefold. It's unique. If you look at your fingerprint, we all have a different fingerprint, just like we have a different genome, and we're each made unique. And so you deserve, prescription medicine that is based on your own unique needs. And then additionally, it's power. So we all have power within, not in the cheesy sense, but in our cells. And your fat cells are one of the most rich and powerful cells in your body for inflammation. And then third, what's important to me is that equality or access to medical care and personalized medicine. It's accessible. You just have to advocate for yourselves. And that's part of my platform as well. I have a training company. I was frustrated with the lack of accessibility to personalized medicine, and so I teach it.
Hey folks, I'm Chris Spears. A little too close. I am the CEO of Orderly Wellness. I am not a doctor, unfortunately. I am a marketing technology person. And when I think about personalized medicine, I think about it from how do we use that word without watering it down so that it doesn't just become like the de facto. What is the role technology is going to play to enable doctors to scale personalized medicine beyond the number of patients they might normally be able to see. And then thirdly for me is, as individuals, we're starting to take more and more ownership over our healthcare and our health journey. So what does that mean to me as a person as I have a conversation with ChatGPT or some other tool to understand my personalized medicine?
Thank you. Very good start. There are a number of expectations out there around how powerful personalized medicine will be, how much it will be taken up by the traditional healthcare institutions that serve us. Will it be the wealthy have access to personalized medicine, but other people don't? So when we think about some of those questions, and when we look across the healthcare industry, we see that personalized medicine still has the expectation of significant year-over-year growth. So we're talking about, sort of low double-digit cumulative annual growth rates between now and the next 10 years. We'll see, right? We'll see if that happens. But Lucy, I was wondering if you could start us off by maybe talking at the scientific level of personalized medicine and help us. I know you're a pharmacologist or pharmacology trained. Could you help us think about some of the science behind it?
Sure, right. So I think pharmacogenetics is one of the areas that come to mind for people when you talk about personalized medicine, right? How do we as individuals handle medications differently? And how do we use that information in order to better target therapy to individuals? So there's some really commonly prescribed drugs, Plavix, codeine, metformin, all of which have very well understood pathways that are affected by our unique genetics. And so I think it's a great example of how personalized medicine should be applied in the general practice of medicine, but isn't necessarily, right? So in the Caucasian population, about 50% of people have at least one mutation in the gene that affects the processing of metformin, the most commonly used starter drug for diabetes management. And 10% of the population have two, right? So they are not going to be, served well by that drug. They're not going to activate that drug. But nobody tests for that before prescribing metformin because it's a cheap drug. The test may or may not be covered by insurance. So instead, we go through this trial and error process of prescribing it. Oh, it didn't work 12 months later. Let's go to second-line therapy. So I love that example because we understand all the science. The tests are available. And we have to ask ourselves the question of why don't we use it, right? And I think this unfortunately comes back to some of the financial drivers.
Joni, you have built your practice around regenerative personalized medicine. Why do you think it's going to continue to explode?
Well, I think we're seeing more clinical evidence that it works. And so just as you had said earlier, we're all thinking we're getting this great care because it's how we were raised or expected to be treated, but unfortunately the system's become overloaded. And so what's nice is that we've been able to create a business model where you can really optimize the patient's health because they come actually for aesthetics. I only see about 6 to 8 patients a day. And so I get to spend about an hour to an hour and a half with these patients. And even on a cellular level, if we're taking their blood, I optimize their microvascular health so that actually the roots to the tree are absorbing the medications. And epigenetics, genetics. How many of you out there probably have peptides on board and you didn't have testing? Well, it's important to know what they could turn into based upon your genetic code. And then additionally, our fat. Optimizing our cells. How do you optimize fat? That sounds weird, right? But even just absorbing for inflammation. And the thing that people don't realize is we age every day. So that's a really big business model. If we're aging every day, that makes it we all need that. But at the same time, it's important for the trust component that patients understand that we age every day because it's not a one and done. So they need to continue to advocate and to be educated or to want to be educated on what's going on in their own bodies uniquely.
Chris, one of the themes of today's conversation is going to be about how do we integrate personalized medicine and all of its use cases and applications into or around the care system that exists today. And I know that as you've built your company, you have focused on that collaboration. Could you talk a little bit about that?
Yeah, I think there's lots of opportunities to collaborate in the personalized space. And, I think about Lucy's story. And, the reality, I think, is that a lot of consumers are now taking that step themselves, right? They might go do that testing to determine whether or not that drug is going to work for them. And I think you can see, the growth in personalized is if you just look at the startups that are evolving in this category from blood work testing and epigenetics and even gut biome, right? There's a lot going on that is now coming directly to us as consumers that then we're going to take back to our medical providers and give them access. But those are still every single one of those startups ends up being a disparate system with a disparate data pool that isn't connected yet. So how are you going to pull the blood work companies into one platform and then the gut biome and the epigenetics and give it to you in a way that you can actually react to it, right? Because that's 110 biomarkers and however many it's just an overwhelming amount of data. So you're going to need some level of technology to sift through that and help you understand what's going to be important to Chris versus Joni when you look at our cases.
Okay, that sets up the next question perfectly, which you and I were talking about earlier, which is if you're on the business side of a health system, right? You have your financial incentives in place, you have your workflow and care protocol in place, and then you have all of these consumers who are essentially operating with their own personalized medicine almost in a cul-de-sac, right? Kind of around and outside of your system. So for the people in the audience, for the CEOs and the CFOs and those chief operating people in the audience, how do they think about the future of personalized medicine? That's for you.
So Ellen and I were talking about, right, that we are still on this value-based journey, right? Like we could have been on this stage 10 years ago and talked about value-based care, and we're still here talking about the value-based care journey. But I do believe we're making progress, and that there, is no path forward for the U.S. healthcare system other than to figure out how to deliver better outcomes at a lower cost. So I think as a business proposition, if you're a health system leader, this is really key to understanding, I want to deliver a better outcome, not just for that population, but for that individual patient, every patient who makes up that population. And how am I going to get there? Well, if I could use the data to tell what's going to be most effective for that patient, not just the efficacy part that I mentioned of something like metformin, but the safety aspect, the side effect management, right? As we can leverage genomic data and testing in order to do that, patient preference, all of us may have different tolerance for the kind of side effects we're willing to put up with in a treatment. And imagine that conversation happening with patients and their families. To me, that really fits nicely into this path we're on for value-based care, where it's a cost-effectiveness question at the end of the day. And I think this is a missing piece as it gets integrated into mainstream medicine to help us get there.
And even quality of life, because how do you define quality of life? Someone that may think their high quality of life is being on bed rest and having different medications 20 times a day, and someone else may be hiking in the mountains in Colorado. And so to me, the biggest part to bring home is really what does the patient define that as? There's neither right or wrong, but it's individualized treatment. And so outlining that with the patient and then executing the plan, but also delegating and collaborating. If you act like you know something you don't, that's when people get hurt. So it's important to have people that are a part of the team that they each have a specialty in.
One of the, I think, points of tension here is around payment, right? So Lucy mentioned value-based care and the fact that those reimbursement models are still being advanced. That landscape is still very turbulent with different rules and a lot of changes in reimbursement rates, et cetera. Both of your organizations are private pay organizations. So you're really counting on individuals or maybe on smaller health systems to serve their patients, maybe with private pay or some kind of a combination of an FSA payment or something like that. Chris, could you comment on how that sort of private pay, hybrid pay dynamic works, and do you think it will change going forward?
As I was sitting here thinking about it, and I hadn't considered it before, I think as a cash pay business, we're in default a value, like if we're not valuable, they stop showing up, right? So I think that's an interesting model. Is like from our perspective, we had a conversation about is your membership a subscription? And no. Like, we don't do a subscription. We don't lock you in. We earn you every month, right? Like, make sure you want to come back and continue to work with us as a company. And that holds us to a higher level of care.
Also, though, for the patients, if you don't mind me interjecting, part of my business is actually a protocol that's over 12 months. It's one procedure every 28 days. That's our skin cell cycle. So the membership aspect somewhat is important a little bit because it gives some compliance aspect. If you're mapping out a game plan and there's not a compliancy component, then people aren't going to show back up because they don't understand that it's important for the result. So we try to create packages or game plans so people understand the compliance, but it is so important that we show our best every day because trust, if the patient can't trust you, they're not going to come back and they're not going to get a good result.
Okay, so trust is actually where I wanted to go next, right? When we were having some of our preliminary conversations, we were talking about all of the stats around erosion of patient trust in the system. And you could look at the rise in private pay, particularly around personalized medicine, as part of the erosion of trust, right? To your point, Chris, I'm going to take this part of my health in my own hands. I'm going to look at my own data, and then I'm going to share my data or share what I believe my values are with my traditional provider or providers. So what happens as the science advances and the trust has to be maintained, which we have all agreed that it has to be maintained, and there continues to be innovation in the space, not to mention enormous noise for consumers, right? Get these 100 biomarkers, do this, do that, take those supplements, don't do that. So how do we navigate through this time of innovation? Who wants to tackle that one?
I think one of the things our medical providers have talked about doing is what is the the reality of some of these therapies, right? Like a hyperbaric chamber and red light room and a green light room and a blue light room, and then I've got salt bath. There's just so much noise out there. I looked at it this morning. There are 12 supplement bottles on my counter, and I'm like, are these doing anything, or are most of them just passing through me on a daily basis? So understanding the reality of what is actually working, I think, is still a missing piece, because it's so easy to just, the Instagram influencer out there promoting whatever they feel like promoting with no background in medicine.
And I would say to that's extremely important, is credentialing and training and always being ready to learn more and creating an accessible program for patients. I have an open clinic on Wednesdays in the afternoon where patients can come and ask questions, so then I'm not getting 50,000 questions all the time. But I think what you're talking about of influencers, that's going to be not a problem, but you'll have people coming in and following compliance of somebody who just Googled something rather than actually having the clinical evidence. So I think partnering and collaborating with platforms and even AI to demonstrate, okay, you have all these genetic markers. How can we tone this down to where then we say, okay, this is the next chain of command for which protocols to follow, so it's reproducible and scalable.
Joni, I know you're also doing provider education, and you're very focused on that. Can you talk a little bit about that, about what you've seen work well?
And that actually just stemmed from frustration. I was teaching aesthetics and regenerative aesthetics before it was cool. God happened to bless my business, and that it just ended up being where we are present date. But what's important of that is it's misinformation. So you have all these different platforms out there teaching, and what are they really, what's the MO, or what's, behind why are they doing it? So to me, the clinical evidence needs to be there in training, and so that's what I've kind of prided myself on, is partnering and collaborating with other companies to have a training platform of that. For people that can't travel, I have an online platform. That's the other thing. So, you're expected to run a clinic, but then also to be updating yourself, on CMEs and such while you go home and have a family and supposed to cook dinner and everything. So providing remote access, and that even goes to your part of remote access monitoring. But I've taught about 350 women and men over the past 2 years, and that aesthetic platform then turned into regenerative precision medicine, because you have to do a good faith exam when you first see someone in aesthetics. And so I saw that as an opportunity to optimize the patient's health, and that began the platform of teaching that.
I would also wonder, what is the difference between innovation and snake oil, and how do you walk that line? Right? So we want to be innovative, we want to try new things, but how do we make sure that we're not just selling something that's useless? And I might mess this up, but I'm pretty sure it was collagen has just come out as having zero impact on us.
Because it's not micronized.
It's a $4 billion category. Oops.
Yeah, it's like trying to fit a Mack truck in a tiny garage. It's a cell activity thing. Someone could tell you that. But.
Well, it goes to the point, I guess, of affordability, right? We were talking about the fact that people who can afford to explore personalized medicine may be well motivated to do that. And then, what about everybody else, right? Who can't afford personalized medicine, can't afford to understand their own genetics, maybe can't afford to have access to a primary care provider, within the established period of time. So, Lucy, your company is a remote patient monitoring company. And one of the things you and I have talked about is the fact that many people simply can't get into a provider. So, and I know that that's not necessarily always an affordability issue. It could be, but not always an affordability issue. But how do we think about access and affordability into the traditional system, and then think about the way that people could use personalized medicine to optimize?
So I think, there are multiple barriers that people face to receiving care, right? Is there a provider in my city, in my neighborhood, who's taking new patients, right? I have an amazing primary care provider. People ask me for a recommendation. I'm like, he is not taking any new patients. I had to beg him to take my own mother. So, and we have this nationwide provider shortage across the board. Nurses, doctors, PAs, it's everybody. So there's that access problem. Then there's do I have adequate insurance? Then there's do I have transportation? Do I have the time off of work? Does my adult caregiver child have the time off of work if I'm older to take me, right? There are all these ways that it is hard to access care, and where I think innovation can address that, right? I mean, we've all experienced virtual care models now, telemedicine after the pandemic, during and after. So, I really think of it as an access issue in part of, I shouldn't have to go to the provider every time I need care. They should be able to come to me, or I should be able to share data with them. I should be able to get my 100 biomarker assay done and upload it to my patient portal, and that system should be able to provide some intelligence and surface to my provider what's relevant to them. So part of this is about that connectivity, and I think as we think about mainstream medicine and what's the intersection with personalized medicine, some of these more direct-to-consumer models, it's kind of how I feel about the whole consumerization of medicine story over the past decade, that much of that is about convenience. It's not that people don't trust their provider. I would argue we all as patients still inherently, in general, trust our providers, but we're looking for more convenient ways to access care. But I don't think by convenience we want to be on an island by ourselves, right? We don't want to be marketed on TikTok collagen and just take it blindly and then find out 4 years later it didn't do anything. So I think, how do we connect those dots between what the direct-to-consumer cash pay market is doing really well, as evidenced by the fact that people keep showing up, right, and are getting value and help? How do we bring that learning back into mainstream medicine so that we are addressing this access and affordability issue there?
I think that's where the collaboration and the training comes in, though. Being able to access it, right? So the platform of being able to have a virtual model, or just like your virtual medicine, it'd be nice to have a virtual training model, and partnering with bigger companies, bigger hospitals, because to me, precision or personalized medicine isn't just a hype, it's the wave of the future. So, even with reimbursement, at some point the tank's gonna run empty. So we have to prevent chronic diseases. It starts with educating our patients and our providers.
Chris, would you like to chime in on this?
I mean, I think from the training perspective, what's interesting as I look at both GLP-1s and hormones, which are categories we're in, is that both of those are just misunderstood, right? So I think we have plenty of patients that come to us from a telemedicine perspective that started off with their primary care, and their primary care just said no. Right, like, I'm not going to write you that prescription for a GLP-1, or I don't believe you have, a hormone issue in pre or postmenopausal, and that's ridiculous.
Just tired. Go get some sleep.
Yeah. Okay, so we've talked about this issue of time, right? So we know we have scarce providers, or becoming more scarce. We know that appointments are down to, lower than 10 minutes, right, or less than 10 minutes. We know that people have less and less time to be able to drive to a doctor's office, sit in a waiting room, whatever that is. But how do we think about time and convenience of personalized medicine and the intersection of this traditional system, which is built on certain financial incentives, certain expectations of patients per day?
That's what keeps me up at night. I'm serious, because we live in a world of innovation where we have access to crazy things like microvascular health and seeing, capillary scope under your tongue and the eye in there with the eyes. And, there's so many things that are right at our fingertips. But my concern is that, and what we need to work on, is having access, but also time. So that these inventions are being made, but we're not utilizing them because we haven't made the time to know that they're even there.
And the time is a function of the financial reimbursement
Absolutely.
system. So how do we think about that? You guys are the pros here. How are you thinking about the best way for a system which has traditional infrastructure, financial incentives, et cetera? What is the way forward? What is the way for them to be able to integrate this increasingly innovative precision and personalized medicine capability? It's not like it's going to stop, right? We're probably just at the very beginning. Who wants to tackle that one?
I think Lucy said it with patient preferences, right? Understanding where they want to be, how they want to be communicated with, when they want to meet with you. Gone are the days where I want to sit in the waiting room for 2 hours past my appointment because why? That shouldn't be a thing anymore, right? I think 43 states enable text-based communication with your doctor to get prescriptions written. Like the other 7 require us to do video calls, but there's no reason for me to go sit in that space anymore. But it's kind of like the whole return to work thing, right? It's an antiquated model that's forcing us back into offices because companies have leases that they are responsible for. And doctors is the same way, right? Like I assume as a doctor you can bill more if I come into the office versus a telemedicine visit?
No.
Well, I mean, there's been a lot of work around payment parity, right, for telemedicine versus inpatient visits. It's hard. It's a big ship, right? It's slow to turn. And, the majority of medicine is still paid for through, transactional CPT type reimbursement models. And we have seen the change there, right? We've seen models over the past 5+ years like chronic care management or remote patient monitoring really gain traction. But, people in medicine don't jump onto something new the first year necessarily because it's a commitment. I had a great conversation last night that none of this is about the technology, I say, as a technology company, right? It's about change management, right? It's about the work that the people on the front lines of medicine are doing, and they are busy, they are, resource constrained. And so when we come in and say, you should adopt this new care delivery model, whether it's remote patient monitoring or, precision medicine, like that is real work that they are having to do to change the way that they are delivering healthcare, figure out how they're going to get reimbursed for it, figure out how they're going to engage patients on it. And so I have a lot of empathy for that, right? It is hard to change, but I think it's happening. I'm the optimist on this.
And that's where the layering comes in, I would say, and teaching the consult from the beginning so that it's not, I have to add this now. It's like when the EMRs came out and we had to start doing our own charting rather than just writing it out. You had to learn the computer systems. So to me, integrating the precision or personalized should be just gently layered in so it's not overwhelming to where it becomes a part of the daily process. And before you know it, you're already doing all these other things. That's a level 4, right? But you're actually practicing good medicine. So it isn't overwhelming.
And I'll just add, I think from our theme of collaboration, right? It's where we can, where you can all learn from each other, right? Of different systems and different practices are doing different components of this. And where it's really working for you, share that with somebody else. Tell them how you're doing it. Tell them how you managed that change process and integrated it into your practice or your health system.
So, Lucy, I'm going to pick on you again. Can you give a case study where you have seen that collaboration work really well? Like a specific clinical use case, a specific set of sort of patient disengagement points or lack of compliance with certain populations where you think that kind of collaboration could be a win-win-win? I don't mean to put you on the spot.
You were putting me on the spot. That's fine.
Totally
That's
put
fine.
you on the spot.
Yeah, I'll give a good one. So March of 2020, we had been talking to Boston Medical Center, which I think of as like the Grady of Boston, right? It's their big safety net hospital, about helping them monitor their high-risk pregnancy population. And we'd been talking to them for 6 months, right? It's a big health system. Contracting takes forever, implementing a new IT project. They call us, can we get this up and running in a week, right? We have just shut down and we cannot bring our new moms with new babies back into the hospital for a blood pressure check. And we want to get this program up and running in a week. That was a true moment of collaboration because we said, sure, we can. Tell us what that looks like, right? Tell us about your patient population. Tell us what your clinical protocols are. This was our first time doing high-risk pregnancy monitoring. We had done hypertension monitoring before, but not in a pregnant population. They have a lot of patients who English isn't their first language. They have a young patient population who doesn't want to talk on the phone, but they want to text. And so we really built out an enormous amount of our protocols and pathways by just asking and being curious with the customer and taking feedback from their patients, right? And we saw the result of they shared with us, patients who would get a automated text message in their native language, Haitian Creole, saying, your blood pressure reading you just took is highly concerning. Please take another measurement and call the clinic. Those patients said, I've responded because it was in Creole and not English, right? And it made a difference, and I was able to be treated and, manage the risk of dangerously high blood pressure. So that was a great moment of collaboration out of necessity.
Joni, I love the fact that you just said lightweight integration, right? Like integrate
Such a
things
lovely
lightly.
way.
Yeah. How might a health system with that big old EHR sitting there, how might they think about lightweight integration?
I would say with the consult at the beginning, know what your focus is and give a top 3 wish list. So we make game plans at my office because how many of you have gone somewhere, especially an aesthetic center, and they'll say, you need this, and you need this, and you need this, and every time you go, it's something else you need. So from an expense standpoint, you're overwhelmed, and you're lost, and they're throwing 50 things at you. And so from the get-go, it's nice because you have a roadmap, and then let's say I'm at a business event like today and someone's in my role, they can look at that top 3 wish list. It's the assessment and the plan. So it creates what we're doing from the get-go. It's just more thorough. And even precursors to like the medication. If he has these 12 medication bottles sitting on his table, why don't we start with microvascular health first? So if it's a standardized, just like standardized procedures we have in protocols, it should be easily reproducible.
I think a collaboration one that I enjoy. So we had a team member come and say, I cannot have the telemedicine company that we work with write a prescription because I'm a type 1 diabetic. And I said, okay, so it's too risky for our telemedicine partner to do that. Why can't you do that with your endocrinologist? And she said, well, even though I'm a type 1 diabetic, I'm not covered under insurance for a Wegovy or a Zepbound like they only cover type 2. So we're in the category. Our doctors can't write her a prescription. Her doctor can't get her covered under insurance. And the collaboration that we did was working with the diabetes clinics to have prescriptions written in a personalized way so that we could submit them to our compounding pharmacies and give her access to a GLP-1. So it started with the patient for us to understand the collaboration, right? A pain that I never would have even known existed, but that she brought to us.
Okay, we're going to take a little pivot here and talk about the risks and challenges. We've talked a little bit about the challenges, whether that's consumer trust or the whole, is it snake oil or is it innovation, right? What are the risks and challenges that you see, right in the near future, the next 12, 24, 36 months for personalized medicine? Chris, do you want to go first?
If there are levels of gray, right? So, you've got the branded GLP-1s, and then you've got GLP-1s that you can get from compounding pharmacies, and then you've got GLP-1s that you can get in a vial from a research lab that have not been, reconstituted, and you figure it out yourself and give your own injection, right? And I think that whole research category is very gray and very scary. I mean, there's plenty of evidence out there around those things, but you're very much putting into an individual's hands, how much am I going to add to this, and how big is my dose, and is this going to hurt me? And there's no governance around it.
Oh, yikes. Okay, Joni?
That would be a risk because many people come to me and they want that done, and I unfortunately will not do that unless we have clinical evidence there that it would work even in microdosing for them. Or pulsatile dosing, because to me it's all about inflammation, and I could geek out forever on that. But from what's out there, he's absolutely correct. With the research, it's not even animal tested, so it's different, right? But that's where you really can collaborate with someone. So when I have somebody who wants a GLP-1, and to me, it wouldn't be, in my scope to say this is what's best. That's when you can collaborate with someone else that is their specialty, right, or that does the testing. I think what's important, though, is that we have IRB studies and we partner with research companies. Earlier today, we had 2 PhDs from different research companies, and I can't wait to talk with them because, you have the School of Engineering, and then you actually have the School of Medicine, and there's a pathway in between both of those. And so, you hear the word collaborate a lot up here, but there's a lot out there, and it just needs to be approached in an organized manner.
Okay, yeah.
So I'll take a slightly different tack on that I think one of the risks and challenges is further care fragmentation.
Yep.
And from a patient-centric point of view, that is not good for the patient, and it's not good for their care team. And then you sort of add, maybe with my provider hat on, compounding the provider burnout situation, right? So we all want engaged, activated, educated patients. And, I try to be that as a patient, right? But we've all talked to providers who will talk about their patient who comes in, who's talked to Dr. Google or, Chat GPT with this long list, and it's kind of like, sigh, right? Like, okay, here we go. And so I worry about that on both sides. I worry about it from the patient's best interest of getting different care in different places because they aren't finding all the care they want in one place. And then I worry about the burden that that's putting on the providers who are trying to do the best thing for their patient, but they're having to piece together a lot of information that they don't have access to.
And I'd say that's where communication is huge. And even in the consult in the beginning, you'll get a list of 8 different providers that people see that are specialists. And usually ask, who do you see? Who are all your people you see? And it ends up being a list of 10 things with 10 medications. But where they're worried about fragmenting, that's where I see it as, secret spy daisy opportunity to be the one who advocates for the person and communicates, to be able to be that advocate. Yeah.
Okay, the old what keeps you up at night question.
I geeked out on that earlier.
Okay, go ahead, Joni.
No, I geeked out on it earlier. I said that we have, all this technology and we're not using it in time. That was mine.
Okay. Chris, what keeps you up?
I think it's the security of all this data flowing between a variety of different partners. Right? So even though we're not, as a cash pay business, we're not a HIPAA covered entity, we are still responsible for a very large amount of health information. And how do we share that with our medical providers and with our pharmacy partners? And how do we consume that from the blood testing companies? So there's just a lot of cyber risk associated with those things.
Okay.
And informed consent. Did we really discuss the risk to the benefits? Did I know that there was an epigenetic test that could then turn on this peptide to cause something else? So,
right.
I think what you mentioned earlier of creating a 2-tiered system where a lot of this innovation is only accessible to, a certain part of our population. I worry about that.
Okay, so this is a relatively new topic. It's a relatively new category. It is coming at us now in these really specific and focused ways, many of which are brought to us through direct-to-consumer models, right? So now let's imagine that we're sitting on this stage 1 year from now in front of an audience very much like this audience. What will we be talking about in a year that maybe isn't even on our radar right now? What could be ahead?
bioharmonic technology, vibration.
Say what that is.
I'm out there with nerdy things, clearly. But we all have different, if you have a glass of water and the ground shakes, it's going to vibrate and it's going to have different cellular structure. Not to completely sound like the hum, but there will be different vibration and wavelengths. It's how we treat wavelengths with pulsatile frequency, even to take a tumor and to break it up, and even how it's exposed to the body. I think it'll be used for target delivery. So I think we'll see exosomes, we'll see mesenchymal or fat stem cell being used to target therapy, to deliver medications, but also has to do with vibration.
Go ahead.
I think we'll be talking about the impact that AI has had on personalized medicine, right? And maybe that's one of the answers to my previous concern is, did that help democratize the availability of this personalized care to a broader audience?
Do you see early AI impact in personalized medicine? And if so,
there.
what is it?
I mean, I think for us, it's accelerating putting the right information in front of the care team, right? So being able to digest thousands of pieces of information, the stack of papers that you get from the previous hospital, and turn that into an insight in 3 minutes. And I think the analysis is that it's 99% accurate, so it's pretty close.
That 1% scares the crud out of me. Always, trust but verify, but I think it's already there now. And I think the biggest thing I learned is how to ask the right questions with AI. Anyone's had ChatGPT here, you could just ask a question, but if you say, acting as Chris Spears, how would you order this, right? So you can get different answers that are pretty specific.
Our time is up. Thank you so much for the great perspectives. Really enjoyed it. Thank you, audience, for your attention. Have a great rest of the day.